Then I want to start with this concurrent session. Hobby is abstract session. So moderator, I'm from Takemura from Kanazawa, Japan, and the co-moderator is
Rashmi Yadav from the Brompton Hospital, cardiac surgeon.
So 4 minutes speak for each speaker and 2 minutes discussion. Please keep your time. So first speaker, are you here? Okay. The first speaker is Dr. Yongpen Chu from the Shanghai, China. The title is Association between early graft failure and subsequently clinical outcomes in patients underwent coronary artery valve grafting. Insight from the dark curve fee study. Please start.
Okay. Thank you, Chairman, and good afternoon to all. I'm Yang Yi from Shanghai Regional Hospital, and it's my great privilege to be here to ICC to present the study from our hospital on behalf of our team. So we launched, here are the disclosures, and we launched the DCAPS trial in 2013, which enrolled 500 patients, and we completed the 1-year clinical follow-up and the CCTA evaluation in order to evaluate the impact of the different antiplatelet therapy on the early vein graft failure. Following that, we initiated the DCAP-FE trial and conducted the further follow-up until 5 years after the CABG. So the current study, the aim of the current study was to evaluate the impact of the early term graft failure on the subsequent 5-year clinical outcomes after CABG. This is a post-hoc analysis combining the data from DCAP trial and the DCAP-FE trial. And the graft failure in this study was defined as the Fitzgibbon grade B or O. And the primary outcome was the 4-point MACE. Here are the results. As shown in the table, among the 429 patients who completed the 7-day angiogram, approximately 12% of the patients experienced the graft failure. And with patients with the 7-day graft failure exhibited a significantly higher rate of MACE as compared to others. And it was mainly due to the more myocardial infarction and repeated revascularization observed in the patients. And no difference was observed in terms of all-cause death or the stroke. And and we also done the analysis for the 1-year graft failure. And the similar result and we get the similar result. So for the patients with 1-year graft failure, the incidence of the MACE was significantly higher. And it's also mainly due to myocardial infarction and the repeated revascularization. And interestingly, more than 6% of the patients in the 7-day graft failure and the 1-year graft failures, most patients who had graft failures were clinically silent. They did not have any subsequent MACE during the 5-year follow-up. In conclusion, the early graft failure was not rare and is associated with subsequent MACE, especially for MI and repeated revascularization. On the other hand, most of the patients with graft failure were clinically silent, and the progression and the subsequence of the early graft failures should be carefully identified. Thank you very much.
Thank you very much. Thank you for your keeping time. And any question from the floor? So you included the all area graft failure, including the LAD and the circumflex.
Yes.
And do you think any impact of the area of the graft failure influenced the MACE?
Yes, we did analysis.
Yeah.
Yes, if we can, I can show the slides after
Can you
that.
put the slides back on, please?
I'm asking the LAD was maybe a LAD area, graft failure should be some impact much.
It's a very good question. Actually, we did analyze this because we calculated the MACE after the graft failure. That means maybe the patient, they get the LAD accrued, they got the MACE before that.
Yeah.
Yes.
Yeah.
So that we didn't calculate that factors. But after the graft failure, the difference is nothing. Yeah. There's no difference in terms of territory.
And between the graft failure group and the no graft group, there are some differences between the hyperlipidemia between the.
Yes. Actually, it's inverse.
What is the biggest problem cause of the graft failure? Maybe.
Actually, for the 7 days, for the 7-day graft failure, in the 7-day graft failure groups, the hyperlipidemia is higher. Yeah, it's lower. That means for the 7-day graft failure, it's probably more due to the surgical technique or acute thrombosis, and it's not due to the lipidemia, something like that.
So maybe you can say that how to prevent early graft failure is very important for the result.
We use TTFM. Yes.
Okay, thank you very much for a nice presentation.
Thank you.
Okay, we'd like to invite the next speaker, Zaid Aboud, talking about racial disparities after coronary artery bypass grafting in recent years, a nationwide analysis.
Good afternoon. Thank you so much for this opportunity. It's an honor to be here and present our work at ICC. I'm Zaid Aboud, research fellow at Aurora St. Luke's Hospital, Milwaukee, Wisconsin. Our work titled Racial Disparity and Cabbage in Recent Years Nationwide Analysis. So the cabbage is the most frequently performed cardiac surgery worldwide. And despite technical advancement in the field with improved cardiovascular outcome after cabbage, studies have consistently shown that African American patients experience higher mortality and post-op complication. For example, a study by Inoma et al. Studied 1 million patients underwent isolated cabbage between 2011 and 2018, found that the African American having higher overall mortality, 2.7 versus 2.1, as well as the 30 days mortality. Mehta et al. Reported that African American in another study having higher unadjusted mortality and major morbidity rates compared to the white patients, 1.8 versus 2.5 and 13 versus 19 respectively. So we sought to evaluate the updated data from real-world database. For that, we use the National Inpatient Sample. For those who are not familiar with the NIS, it is the largest publicly available database in the US. It's collaboration between hospital, state, and federal level, made purposely for the research, for which we utilized the ICD 9 and 10 based on the year to isolate the patient of interest and the outcome. The primary outcome was inpatient mortality in African American compared to other race, more specifically the white, and the secondary was the complication. Baseline characteristic has been compared by standard tests like t-test or chi-square, and alpha was 5%. So in the result, we evaluated a total of 929,000 patients who undergone cabbage, of whom 64,000 or 7.1% were African American. And the majority, as shown here, were whites, representing 78%. The baseline characteristic of cabbage patient among the African American cohorts and white listed here. The African American patient had less total number of females, which is expected from the smaller sample size of 64,000. But what is important is the the cohort was younger, 62 versus 66, and also having higher comorbidities index, including hypertension, diabetes, CKD, CHF, end-stage renal disease. Overall, the Elix-Hauser comorbidity is higher, 7.4 versus 4.2. So in the mortality among the African American patient, the mortality rate decreased from 2.5 to 1.5 in 2019, then it increased a little bit, but not statistically significant, but overall the trend is decreased. Similarly, the mortality in white population underwent CABG is also decreased, but there is always statistical significance between the two cohorts. Overall mortality was higher in the African American, 2% versus 1.6, and that's statistically significant as well. The odds ratio of mortality was 29% higher in the African American, and this is independent risk factor when adding their year, age, females, comorbidities, and we also included in this model the hospital bedside region and teaching status. Post-op complication was significantly higher in the African American in AKI, stroke, bleeding requiring transfusion, epicardial effusion or tamponade, surgical site infection, as well as the MI. These are the percentage. It is higher in the African American in all these post-op complications.
Could you go to your conclusion slide, please?
Sure. The next slide?
You're out of time.
Oh, I'm sorry, yes. As well as the post-op complication is higher. The length of stay is relatively same in the African American, about 10, but higher than the white by 1 or 2 days. Total cost is also higher in the African American compared to the white, as well as the inflation-adjusted cost. In conclusion, the African American undergo CABG having higher mortality and post-op complication, and these persistent disparity we think could be mitigated by optimizing a pre-op conditions such as CHF, blood pressure, which may help the mortality. And thank you so much. Sorry about that.
That's okay. Thank you very much. Excellent presentation. Are there any questions from the floor? No questions. I really just have a comment. These are quite sobering data, isn't it, to see that a particular group of patients are disadvantaged for a whole range of reasons with worse outcomes. And is there some sort of initiative to try and address these? I imagine it's a very similar situation to worse outcomes in women patients. And similarly, you've shown in Afro-Caribbean this difference. Did you look at other groups? Did you look at differences in Asian groups or Hispanics, or did you only specifically look in the black population?
Thank you for the comment. For this specific presentation, I just compared to the white.
African American.
But for the paper, we're gonna be extensive a little bit to compare to other races.
So you'll be looking at other racial groups and see
Yes.
whether they are also disadvantaged compared to the white group.
Yeah,
Right.
that's the plan.
Okay, thank you very much.
Absolutely.
And the next is also by you.
Yes.
Oh, good.
Yeah, I was thinking that.
The salary is the national inpatient outcomes and resources utilization after coronary artery bypass grafting are 6 specific analysis. Please continue.
I'm sorry. I don't have it here. Can we increase it?
Yep.
Yeah, thank you so much. So in this study, we're comparing female to male outcome. This is the data has been reported that the mortality and post-op complication was higher in the female compared to male. For example, Robinson et al. Included 48 studies which showing an increased mortality for adjusted and unadjusted. Additionally, post-op, more specifically myocardial and stroke, was higher in the female than the male. And recently, Lagrange et al., including the meta-analysis, 23 studies showing the similar prognosis in female compared to the male. So we use the same NIS 2015-2020 and we compared the mortality post-op complication. A baseline characteristic of CABG in females versus male, the female represented 24% of the cohort, and they were slightly older by 1 year compared to the male's counterpart, and additionally having more percentage of African American, and most importantly is higher comorbidities. Nearly more than half of them, 55%, having diabetes. In addition, hypertension, CKD, CHF was also higher in the female. They were male having higher percentage of hyperlipidemia, AFib, and smoking, and that's the exception in our study. The mortality among female patients, the mortality rate decreased from 2.5 in 2015 to 1.6, and that's statistically significant. Then it increased a little bit in 20, it's kind of borderline 0.5%. The mortality rate among the male consistently following the same trend decreased from 1.9 to 1.2. The overall mortality in the female patient were nearly double of the male counterparts, 2.5 versus 1.4. There is a 40% higher odds ratio of mortality being female alone. Additionally, the age, race, other than white, increase the mortality, the odds of mortality, as well as the comorbidities, while the larger bed size hospital associated with a little bit of productive outcome. Post-op complication was significant in the female having a higher percentage of stroke, a bleeding requiring transfusion, and pericardial effusion tamponade, and MI, while the AKI and surgical infection was not statistically significant. And the female having 30% higher odds of TIA stroke compared to male, as well as bleeding of 67% higher. The length of stay has been decreased for both genders by relatively one day, but still a longer length of stay in the female compared to the male. Similarly, the total cost nearly identical for both, although the female started a little bit lower, but at the end of the day, there is no statistical significance between the cost. And this is applied for the inflation-adjusted cost as well. In conclusion, the female having higher mortality and higher risk for bleeding, stroke, and MI compared to male counterpart after the CABG. And once again, thank you so much for everyone.
Thank you very much, keeping your time. Any question from the floor? So maybe you analyzed using the national database, and previous one, nationality comparison. This is sex differences. So what is the biggest cause for the female for the bad result after the CABG? There is no exact probably reason, but there is multiple hypotheses. For example, the age relation differences, hormonal changes, especially age-related. Additionally, there is like the technical difficulty, probably with the surgery. I don't know. In this morning session, you smaller body and vessels, smaller body and mammary, and technically it should be much difficult than the male. Any comment?
But just that you expect, looking at publications and things, that women are expected to present approximately 10 years later than men because of they're protected during the reproductive years from coronary disease. Having said that, I noticed in your presentation that there was only a 1 year age difference. So the male patients were 65, the female was 66. So we can't really attribute this to age. I imagine it is a combination of intraoperative and other comorbidities which were higher. Although interestingly, the women had less AF pre-op.
Yes.
The men had more, but a large proportion, a third of patients were in AF. That's quite a high proportion for coronary surgery, suggesting that they weren't all straightforward patients, that they must have either valvular disease or for some reason developed atrial fibrillation in addition to developing cardiovascular coronary disease.
Yeah, absolutely. I think that there is also a limitation in this database we need to consider as well. It is mostly administrative data, and we are kind of blind for imaging, treatment that's done during or after the surgery. But you're absolutely right.
What is your idea for the better strategy for the female coronary artery bypass grafting? What point we should do?
We think it is like both for even the African American and the female as well. Optimizing these comorbidities pre-op could significantly help the post-op mortality and the complication.
Okay, thank you very much. Thank you.
Thank you so much.
Thank you. I'd like to invite the next presenter. It's Dr. Hanil Kang, talking about left atrial appendage closure in conjunction with coronary artery bypass graft surgery in the United States. Thank you.
Hanil is not available, so I'm Yang Zan, representing the group. So thanks for the opportunity to present our research work. We have no disclosures. So atrial fibrillation is very common among patients undergoing cardiac surgery, including CABG surgery. Left atrial appendage has been known to reduce the stroke risk. Surgical techniques include left atrial appendage resection, ligation, and the use of external exclusion devices. With the new recent evidence, such as the last 3 clinical trials that demonstrated a significant reduction in the rate of stroke and systemic embolization, it is currently class 1 recommendation from the society, which is class 2 recommendation previously to perform left atrial appendage closure in conjunction with cardiac surgery procedures. So the question is, what's our real-world practice in the United States? So we aim to investigate on the surgical practice patterns of LAC in conjunction with CABG surgery, including trends, patient demographic outcomes, hopefully to shed light on this subject. As the speaker previously described this, we use National Inpatient Sample Database, which is one of the largest all-payer publicly available national databases in the US. So it contains roughly 7 million observations annually, which is about 20% of the total in-hospital admissions. We look at the year between 2016 to 2020 and identify adult patients with the diagnosis of AFib undergoing isolated CABG procedures. We divided the group into 2 subgroups with LAC and without LAC. The second analysis is about the risk prediction and the trend. We identify a total of 5,854 patients for estimated just over 250,000 patients with AFib undergoing CABG surgery. So here you can see there's a clearly upgoing trend over the years. However, even in the most recent year, the year of 2020, there's still just about 20% of patients having left atrial appendage closure. And for patients with the chronic atrial fibrillation, the rate is just about 50% or less. So we compare the demographic of the 2 groups, and they differ significantly. So the patients with the LAC actually were older with the more comorbidities. And their outcomes were similar, especially after adjusting the difference in demographics and outcomes and the baseline characteristics. The LAC group actually, interestingly, had a lower risk of bleeding, but a higher risk of cost. We identified some predictors, including the age, male gender, white race, elective surgery, and some comorbidity, including CHEST-2 score and concomitant ablation procedures. However, female gender, non-white race, and active smoking was negative predictors. So in conclusion, our study shows utilization of LAC in conjunction with CABG surgery despite an increasing trend. We investigated on the surgical practice and found a surgical pattern that may suggest a selective approach to the management of left atrial appendage. This may help identify potential barriers to the implementation of the current guidelines.
Thank you very much for your presentation. Are there any questions from the floor? So my main question for you, of course, is now concomitant AF ablation is a class 1A recommendation for patients undergoing cardiac surgery for any other condition. I imagine this very large number of patients had no AF ablation whatsoever and a very low percentage of left atrial appendage closure. Any thoughts about why this might be the case? And have the trends shown increased uptake in AF ablation? Because there's a recent publication that shows that you add more value by doing AF ablation in CABG patients than doing an extra graft.
Yeah, that is exactly our hypothesis when we started doing this research. Because on one side, there's clearly guideline and evidence, but in real practice, including myself, I was just wonder, which patient would benefit more from left atrial appendage closure or ablation procedures. So here we just want to see if there's clearly sort of an algorithm surgeons use. But certainly, according to guideline, it should be a universal practice. But here we clearly show it's a selective approach.
Yeah.
So, but one question is if the universal approach is really cost effective. Adding additional time on the procedure, but certainly atrial clip is easier to apply, but in the past we had to cut and sew, that increased the risk as well. But certainly in the future, I think it requires a good discussion about how we approach it to left atrial appendage.
Yeah. And do you have information from the database whether these were all externally excluded left atrial appendage or were they also hands-on?
We don't have the data, certainly.
So
it's an administrative database as the others presenter described, so we don't really have a lot of data on the surgical techniques.
Yeah. And any concerns about the circumflex graft when you have that?
Sorry?
The circumflex graft, do you have any concern about lateral wall grafts when you put the appendage clip on?
Yeah, exactly. So in my practice, sometimes I wonder if I want to clip the left atrial appendage when I had to do the circumflex bypasses. So, but we just don't have the data. Yeah, maybe looking into, the STA database, for example, that may give us better idea.
Yeah. But thank you for highlighting this. This itself might be an impetus for change. Thank you.
Let's move on to number 5. Dr. Maria Comaniti. Is she here? The title is Incidence and Predictors of Repeat Revascularization Following Multivessel Coronary Artery Bypass Grafting, a 21-year follow-up study. Please start your lecture.
Thank you. Hi, everyone. My name is Maria. Thank you for the opportunity to present our work today. And today I'll be sharing our results from Harefield Hospital from a 21-year follow-up study on patients who underwent multivessel coronary artery bypass grafting. Specifically, we will be presenting the incidence and predictors of repeat revascularization. As a short introduction, CABG has consistently demonstrated its ability to deliver long-lasting results, but despite of this, the need of repeat revascularization is sometimes needed and can impact patients' outcomes. Current evidence suggested that repeat revascularization can be due to different factors such as the surgical technique or conduit quality, medication adherence. All these factors can impact the long-term success. And through this retrospective analysis, we wanted to explore if the operative technique on pump versus off pump affects this outcome in the long term. We performed propensity score matching of all patients who underwent CABG at our center between 1996 and 2017. The initial cohort of patients included around 10,000 patients, with more than half of them undergoing off-pump CABG, and after matching, we had 4,421 patients in each group. Although there were some differences in terms of preoperative characteristics after matching to all the covariates, we were left with well-balanced groups. This slide shows the intraoperative characteristics. We observed that the on-pump group had higher proportion of cases where only venous grafts were used, as well as more cases with single arterial grafting, while the off-pump group received more total arterial grafts. This slide shows the total number of post-operative interventions, and we can see that among the 405 reinterventions which were recorded, revascularization accounted for the majority of them, representing 72.6% of the cases. Breaking this down further, most revascularization procedures were PCI to the native coronary circulation, followed by PCI to grafts, and followed by reduced CABG. Breaking this down further, by the surgical approach, 61% of the patients who required repeat revascularization were patients who had on-pump CABG, and the rest, 39%, were in the off-pump group. These Kaplan-Meier curves show the long-term freedom from repeat revascularization, and at 20 years, there were differences between the two techniques, but they did not show statistical significance. Using Cox regression analysis, we identify significant predictors that were associated with higher likelihood of repeat revascularization. We can see that the age was associated with reduced likelihood of repeat revascularization. And also, importantly, the surgical approach of pump or on pump was not identified as an independent predictor of repeat revascularization. Of course, like any study, ours is not without limitation, but we can summarize that our study demonstrated low rates of repeat revascularization following CABG, and we did not observe any significant difference in the rates of revascularization between the two techniques.
Thank you very much. Thank you very much. So usually in the literature research, you said OPCAV have some high rate of the revascularization, but in your institute, there's no differences between the on-CAV and off-CAV. Can you explain something about the reason why your result is very much better than the literature?
We think that experience of the surgeons is one of the key components of making.
So the selection of the on-CAV, off-CAV depends on the surgeon's decision?
This can be one of the explanations. In our center, surgeons that did these procedures were highly experienced surgeons.
And in the final slide, there was no the age and the off-CAV does not mean does not have some impact of the revascularization. What is the biggest reason for the revascularization?
Age was associated with lower rates of, or lower likelihood of having repeat revascularization, probably because as the patient get older, they would be likely to have repeat revascularization. But yeah, off pump was not an independent predictor of this outcome.
Any question? Okay, thank you very much for nice presentation. Thank you.
Well done. I'd like to invite same topic again. Trends and early outcomes in female patients undergoing off-pump CABG in the UK, presented by Jeremy Chan.
Good afternoon. Thank you very much for the invitation. Today we'll talk about the trend in early outcome for female patient undergoing off-pump CABG in the UK. I have no disclosure. I think from this morning's talk we have identified that female is different cohort, different subgroup that we have to draw different attention. There will be different baseline anatomical and clinical characteristics. The coronaries are quite often a bit more spasmic and more complex and technically challenging. But looking at the National Registry, so we identified that we have a need to increase the amount of surgery performed in female. But looking at the National Registry, what is the reality, what is the proportion of female actually underwent surgical revascularization, at least in the UK, that we want to demonstrate. And another topic that hasn't really been touched on this morning is whether female patient would benefit more from off-pump than on-pump revascularization. So we looked at all female patients who underwent first-time elective or urgent isolated CABG between 1996 to 2019 in the United Kingdom. We compared female who underwent isolated CABG who had off-pump technique versus on-pump technique. And some of the outcomes we looked at is in-hospital mortality, return to theatre, cerebral vascular accident, return to theatre twice, deep sternal wound infection. And when they exclude the patient that has missing variables on gender, patient who had previous cardiac surgery, emergency or salvage procedure, or they underwent concomitant procedure. Statistical analysis was performed between the two groups because obviously there will be more patients who underwent on-pump. So we matched them using inverse probability treatment weighting. The distribution was not symmetric, so data was presented using median and interquartile range. And these are some of the statistical tests that we used. And after a match, they all match with a standardized mean difference less than 0.1. A total of approximately 130,000 female patients were included over the last 23 years. Looking at the graph on my right, your left, we have looked, there is a trend of reducing proportion of female patients underwent surgical revascularization compared to male. And there's also a reduction in off-pump surgery offered to female patients. However, when compared the match group, female patients who underwent off-pump coronary artery bypass graft had a lower mortality. We have further subgroup analysis looking at the results after 2010, which demonstrates mortality reduced in both groups, but still have a superiority of off-pump in these cohort. Less return to theatre, less stroke. No difference in dialysis and deep sternal wound infection. In summary, there's a reduction in proportion of female patients underwent surgical revascularization in the UK, and there's also less off-pump being offered to this subgroup of patients. However, when compared to on-pump CABG, off-pump were associated with a lower in-hospital survival, stroke, and return to theatre due to bleeding. Thank you very much.
Thank you very much. Are there any questions from the floor? No, just to clarify your last slide. So the patients who had on-pump CABG had more stroke, lower survival, and the third outcome?
Return to theatre for bleeding.
Return to theatre for bleeding. What's your hypothesis? Why do you think off-pump surgery is better? So it's quite a complex thing to decipher, but I'd like to hear your thoughts. Why do you think that women with smaller arteries, smaller conduits, more fragile tissues are doing better with off-pump surgery? Do you think it's a surgery or is it the surgeon?
I think it's both the patients and the surgeons, and in addition, so I think from a patient perspective, and that's one of the limitations of all propensity score matching, there are things that you can't match. So maybe sicker patients will go for on-pump by default, similar to what we see for all patients really. I think off-pump, at least in the UK, are only performed by surgeon who is actually interested in this technique. So perhaps a subspecialization is the answer.
Okay, any other questions? Thank you.
Although you showed of curve will bring the better result for the female, but the rate of the of curve for the female is reducing degrees. Why is that?
Well, I think there is many reasons for that, but one of the reasons is there's a lack of evidence between on-pump and off-pump, although female is hugely underrepresented. And the training, many deaneries or many regions in the UK, trainees will have no exposure to off-pump coronary surgery during their training. So if they haven't got exposed during their training, they wouldn't be able to perform when they graduate.
Another very interesting topic discussed in the previous session was about anemia and how that impacts outcomes in women. Were you able to look at the hemoglobin levels and whether there was a difference in off-pump and on-pump, and whether that was the reason why women patients are doing better with off-pump CABG?
Yeah, we can, but I think hemoglobin is not really a compulsory item in the national registry, so there's a lot of missing data. So I'm not sure how accurate that will be.
Yeah. Okay, thank you very much for your excellent presentation.
So the speaker is again Maria Comaniti from the UK. The title is a comparison of in-hospital outcomes, 30-day mortality and long-term survival of female undergoing off versus on-pump coronary CABG. 27-year propensity score match study, please.
Thank you. We would gladly contribute to the ongoing discussion, and we can present our experience at Harefield Hospital in terms of in-hospital outcomes, 30-day mortality and long-term survival based on this 27 propensity score matching study. I'll skip the introduction slide. Again, this was a retrospective single-center analysis. We included all female patients who underwent off-pump or on-pump CABG between 1996 and 2023. We propensity score matched the groups, and we did univariate and multivariate Cox regression analysis. Our initial group consisted of 2,397 female patients, and after propensity matching, we were left with 949 patients in each group. Again, we adjusted for all the covariates, and we were left with well-balanced groups. In terms of in-hospital outcomes, the results here are shown in numbers, not percentages. We observed that the off-pump group was associated with lower rates of tracheostomy in females, and 30-day mortality in the off-pump group was lower as well. When we looked at long-term survival, the differences between on-pump and off-pump became even more pronounced. At 20 years, the survival rates for females were 68.9 in the off-pump group and 51.4 in the on-pump group, with significant p-value. This forest plot illustrates the predictors of long-term mortality in our cohort. We can see that age, congestive heart failure, diabetes, hypercholesterolemia, hypertension were all significant predictors of increased long-term mortality, emphasizing the impact of comorbidities on the long-term survival of these patients. However, off-pump, on the other hand, was associated with lower long-term mortality in this group. We can conclude that our study provides convincing evidence supporting the use of off-pump in female patients. Off-pump was associated with better in-hospital mortality and lower rates of long-term mortality as well.
Thank you very much. Nice presentation. Any question from the floor? So usually, this is very difficult to show the differences between the off-cab and on-cab, and also many papers said the off-cab will bring less anastomosis number and not a good result. What is the reason why the off-cab for the women bring so better result? I
didn't include it in the slides, but we did look at our index of revascularization, and there were no differences between the two techniques.
Okay, please.
In our hospital.
I find it interesting looking at these last two studies and your study right now in comparing on-pump to off-pump. I mean, these studies have been going on for 20-something years, and we have a recent study in the United States looking at over 1 million Medicare patients. And so it's just been studied so exhaustively with really little difference. And over those decades, we come to understand that there are certain surgeons and patients that may benefit from a technique. It's a clearly more difficult technique. But general comparisons to me don't shed that much light on it. I want to know exactly what the difference is. So if you go on pump, your fibrinogen is going to drop. And if you do it off pump, your fibrinogen is probably not going to drop unless you have a bunch of bleeding. But the general comparisons that one surgeon or a group of surgeons get better results in off pump, we've been doing those studies for over 2 decades. And so I would just make a call that we need to go beyond these general comparisons and really ask very specific granular data, or say, why does this one surgeon get a better result than this other surgeon? And it may be training, it may be skill, or it may be specific teachable techniques. But I guess my question for you is, what actionable data do we get out of this? Would you really recommend doing off-pump surgery in women in general to the average surgeon? I think that would be a dangerous recommendation.
I'll let Mr. Rajak answer to this question.
Yeah, short comment, one question, please.
Short comment. I mean, disparity between operator, interventional cardiologists or surgeon is huge, and never published. I mean, if you look, to take an old example, Syntax, for instance, we were capped after 40 patients in all institutions, so it's, and you have institution there, 0 MACE surgery and 0 MACE PCI. And you had also 100 MACE for PCI. It's amazing. It's amazing. And we have a few times not published on site, but published on disparity between country and continent. It's huge. I mean, it's one of the most difficult papers that we have written is the disparity. So I think it's good in the protocol when you do a randomized trial to require that you have an on-site analysis. Okay. Even the last study favor Europe. I have seen in one journal a version with an on-site analysis. It was turned down. In the next journal, it was no longer there. Okay.
Thank you very much. Comment. Yeah. I'm sorry, we are very behind with the schedule.
Shall we let Dr. Raja answer because he's the lead author on the paper?
Thanks very much. I think the comments of my colleague at the back are pertinent, and I think what we need to stop doing now is comparing on-pump and off-pump. I think this is a redundant debate. We should not be discussing off-pump and on-pump. I think we have to move on from comparing off-pump to on-pump to recognizing that each one of them has got a specific place in the armamentarium of somebody who calls himself a coronary surgeon. I think coronary surgery is not just doing a lima and 2 veins on pump every day. There will be patients who would require off-pump, and if off-pump, and I'm sure that data out there confirms that when off-pump is performed by a surgeon who does off-pump every day, his results are going to be better than somebody who does it once in a blue moon. This is not an operation that you're going to wake up one morning and start doing. This is an operation that requires systematic training, not just of the surgeon, but also of the team. This is not an operation that is done by just the surgeon. It is done by the anesthetist along with the surgeon and the rest of the theatre team. So I think, we need to, and I'm a big believer that, I don't get into this, argument about which is better. I think both are good, provided they are being performed by good surgeons. And I can tell you that if you were to go dig deeper into this data, you'd realize that off-pump surgeons in this particular institution tend to do more arterial grafts. They are probably surgeons who are happy to take on more challenging cases and deliver the same sort of revascularization strategy that they would offer to somebody who's low risk as well as to someone who's high risk. And that is what, in the end, differentiates, why certain cohorts of patients do better.
Okay, thank you very much. Thank you very much for a nice comment. Thank you very much.
Okay, the next talk is comparative assessment of long-term results of prevention strategies for the new onset atrial fibrillation in coronary artery bypass grafting by Vadim Papav.
Okay. So
Okay, go for it.
So skip to the 9. The Dr. Ogabek Job. Okay, the title is the effects of the posterior pericardotomy on the incidence of the AAF after op-cap surgery. Please start.
Thank you for the opportunity to present our results. I'm Islam Jan Sharipov. I'm from Uzbekistan, and I'm representing Center of Cardiology, Republican Specialized Center of Cardiology, based in Tashkent, Uzbekistan. I have one disclosure. I'm off-pump cardiac surgeon, and today's topic will be dedicated to the posterior pericardiotomy during CABG surgery. It's by the literature, it's reported that atrial fibrillation appears in the 3 to up to 40% of coronary artery bypass surgeries, and the purpose of our study was to evaluate the effectiveness of pericardiotomy, this maneuver, in reducing the incidence of postoperative AF in patients undergoing off-pump CABG. Study was approved by our ethical committee, and the patients were given consent for this study. We started this study in 2022 with the aim to reach 400 cases in complete and 200 with the pericardiotomy, 200 without. The study design was that it's a prospective, randomized, doubly blinded study. And all the patients recruited for this study were assigned for isolated coronary artery bypass surgery. In pre-op period, all the patients underwent daily ECG registration Holter monitoring, 24 hours registration of ECG, and if there was any episode of AF, 30 seconds and more, these patients were excluded from the study. After, on the day of surgery, the team opened the envelope and the surgeon was assigned to do or not to do pericardiotomy. And after the surgery, for 5 days, all the patients again underwent daily registration of 12-lead ECG, analysis of monitoring data, and on the third post-operative day, patients again underwent Holter monitoring of ECG for 24 hours. So 200 patients were divided randomly into 2 groups by 100 patients in each group, and basically all the pre-operative data actually was same in both groups, without any significant differences in these both groups. All the surgery was performed off pump. Revascularization rate was 3.2 in 3.3 in both groups. Pre-op Euroscore was around more or less same. During the analysis of post-operative period, there were no significant differences in the course of post-operative period in both groups. During the analysis of results of ECG monitoring and the Holter monitoring, we only can detect that AF was registered, any episode of AF more than 30 seconds was registered in 22% in the group of pericardiotomy and 38% on the group without pericardiotomy, which means around 42% decrease of incidence of AF after CABG surgery. As a result, we can conclude most of the 75% of episodes of AF was registered on the day 3 post-operatively, and we can conclude that this simple maneuver can significantly reduce the incidence of AF after CABG surgery. Thank you very much for your attention.
So maybe I want to ask about what is the mechanism of the pericardiotomy to reduce the AF? What is the mechanism, reason?
In theory, they say that after we open the pericardium, after the surgery, basically it's not closed, and the pericardium forms like sac behind the heart. And the deepest point is just behind the left atrium. So there are several reasons why they say that it's just mechanical irritation by the thrombi. Second is products of degradation, thrombi degradation can cause also chemical irritation after the surgery. Because it's strategically localized just under the left atrium, this can cause atrial fibrillation. Yeah. So just we were cutting the pericardium just in the lower point where usually we put lima stitch. So just between inferior vena cava and the left-sided pulmonary veins. So this is the deepest point of pericardium. And when you open this part, the blood drains directly to the left pleural cavity. So there is no reason for collecting of blood and products after the surgery.
So after your result, do you do this technique for all patients now?
Yes, we completely switched to, and more, because we just started minimal invasive surgery program, I mean the mixed cap program. So we switched on also in this setting of patients.
Thank you very much. We'll move on to the next talk.
Thank you.
Off-pump total arterial revascularization using bilateral internal thoracic arteries, Y-graft with aortic no-touch technique, 15-year follow-up by Dr. Miklos Bite.
Dear auditorium, thank you for, first of all, I want to thank the the organizing committee for accepting my presentation.
We have the wrong presentation.
Sorry, yeah.
The communication team?
Sorry?
Yeah,
We have a wrong
the correct one.
presentation.
This is the one, yeah. So now somebody is using the...
Are you able to... Yep.
Okay.
Okay. The objective of this study was to analyze the early and long-term results of the off-pump total arterial revascularization with BIMA anaortic technique. And therefore, all patients which were referred for CABG were operated with this technique by one surgical team under my leadership. Almost 800 patients were operated. The mean age was 65 years, 36 to 90 years. Ejection fraction between 15 and 65%, with 10% poor left ventricular function, moderate almost 30%. Cerebral disease was present in 68% of patients, and the left main involvement was 26% of all patients. 27% were female, and regarding diabetes, 25 almost percent were non-insulin dependent, 10% insulin dependent diabetes, and less than 2% treated with diet. Pre-op PCI was present in 15% of cases.
Another slide that
Sorry?
you're reading the results. Do you have another slide to demonstrate that? It's not showing here. Oh, thank you.
Oh, okay. Yeah. And yeah, well, I won't say this again. The graft number was between 2 and 7, a mean of 3. Thank you. Mean of 3.18. Yeah, so this was the patient cohort. This is the aspect of the Y graft, which is usually used in this operation, with the lima in situ and the rima attached end to side to the mid portion of the lima. And we also used baby Y grafts, in which case the rima was in situ and the Y graft was performed from the lima. We have here an intraoperative video. We use the retrocardial stitch to elevate the heart. I make a quite large anastomosis between 7 and 10 millimeters for the Y graft, and we always start revascularizing the anterior wall. This is the final view of a 5 graft bypass, first diagonal and lima and LAD with lima, and rima Y graft to the first, second obtuse marginal and posterior descendant artery. Several patients were checked with coronary angio. This is the aspect of 4 grafts. This is the next one is another 4 grafts with this technique. This one is 5 grafts, first diagonal LAD, and OM1, OM2, and PDA. We can notice here that even the PDA part, the most distal anastomosis, has a very good flow, and this is a 7 graft patient. This is a coronary CT angio of 7 graft patient. Regarding results, the 30-day follow-up, the mortality was 1.27%, the reop for bleeding was 0.76%, deep wound infection 1%, neurological complications very low, and renal failure also low. With regards to late results, the Kaplan-Meier showed the mortality at 15 years of 12%, with a significant difference only when we compare the older and younger patients. Regarding gender and left ventricular function, there were no significant differences. Similar, the PCI was quite low, below 2% at 15 years, with no significant differences between the two the subgroups we studied regarding gender, age, and left ventricular function, and also the stroke, the third hard endpoint, was quite low, around 2% at 15 years, with no significant difference between the subgroups. So, based on our results, the aortic no-touch technique is thought to be a top strategy in coronary artery interventions. And despite the off-pump and the use of beta, neither the anastomosis quality nor the number of grafts were affected. As expected from the aortic no-touch technique, the early stroke incidence was very low. With the skeletonized harvesting technique, the incidence of distal wound infection was low, 1%, even in diabetic patients. And the results are reproducible regardless of gender, age, and left ventricular function. Thank you for your attention.
Thank you. Those are really excellent results. In the interest of time, I'd like to move on to our next session. Thank you very much. Great results. Amazing work.